My whole goal of this channel is to help people pass the National Registry for paramedic and for EMT on the first try. Another thing I'm trying to do is help instructors understand content that is challenging. And endocrine emergencies is one of these challenging subjects that people tend to struggle with. So I created a small lecture to help you get through this. Now, not everybody can just read the textbook and understand everything. You need to understand that. Maybe you benefit more from listening to somebody explain it in detail. If that's you, you can go ahead and just listen to me like a podcast while you walk or while you drive. Maybe you want to sit down and take notes. However you benefit from studying, go ahead and do so. Let's go ahead and jump into some emergencies from the endocrine system. So the interesting part about the endocrine system is all of the organs are like rogue organs. They're scattered throughout the entire body. It's not like any other anatomy system throughout the body. Now, there's several different glands that I think are important that you understand the emergencies of, and I'm going to label them out, 8 of them. We're going to be looking at Myxedema Coma, Graves' disease, thyroid storm, hypoglycemia, DKA, HHNS, Addison, and Cushing Syndrome. So the first one I want to go ahead and talk about is Myxedema Coma. Now, as you can see up here in the top left, I have listed the endocrine gland that is affected. With Myxedema Coma, it is hypothyroidism. And there's going to be one common theme that I'm going to be discussing with endocrine disorders, and that is that they can be pretty challenging to diagnose. A lot of these go undiagnosed, and people have problems through years throughout their life. And it's unfortunate, but you have to understand them as a student. If you're taking an exam, there are buzzwords that are going to be said or discussed when you're reading about a patient that should jump out at you that this is the endocrine emergency. Let me talk about those with Myxedema Coma. So first thing I want you to remember is, yes, it's hypothyroidism. So if you ever look at a patient's med list and you see something like levothyroxine, that patient suffers from low thyroid hormone. So they're supplementing the thyroid hormone. Some signs and symptoms, fatigue and weight gain are huge on these patients, right? You hear patients that say, oh, I'm having a hard time losing weight, or I have a thyroid issue. That's why I can't lose the weight. When somebody has hypothyroidism, their metabolism slows down drastically. And this is why they have weight gain. Another thing that you're going to note here on the text is cold intolerance. I know that sounds kind of challenging. It's kind of like a word soup, but whenever they use the term cold intolerance, it just means the patient is so cold that they can't tolerate any more cold. Same thing with heat intolerance. The patient's so hot, right, that they need to be cooled down. So whenever you see the term cold intolerance on an exam, just know that that patient is hypothermic. So bradycardia, hypothermia, hypotension. And when these patients start to have a decrease in blood pressure, they actually start to lose perfusion to their brain, and this is why they become altered. Some of these patients in your exams, they might be unresponsive, or they could just be confused. But remember, cold skin. Another term that does get thrown around a lot is the term waxy appearance. It's like a glazy skin. So they say that the patient looks waxy, the patient's altered, the patient's cold to the touch, right? These are all different signs that the patient's going into a coma known as Myxedema Coma. Now, talking about treatment with Myxedema Coma, the first thing that I want you to pay attention to is airway management. Remember, I'm mentioning that this patient could potentially be in a coma with bradycardia and hypotension. So what are you suspecting the respiratory drive to be? Maybe shallow breathing. Maybe it's not adequate to sustain life. So considering advancing the airway and ventilating for that patient is extremely important when talking about Myxedema Coma. Another thing I want you to think of with hypotension is the replacement of fluids. Okay. Giving volume to this patient is going to assist with maintaining a blood pressure of at least 90 systolic, or trying to keep that MAP, that mean arterial pressure, above 70, all right? Monitor for hypoglycemia. Pay attention to that. Hypoglycemia is a common sign and symptom that could potentially be found with hypothyroidism. So be mindful of it. Ultimately, this patient needs hormone replacements. Again, they have hypothyroidism, so they need thyroid hormones. We don't give that in the pre-hospital setting, but we just need to know that that patient needs that ultimately. Next one here, I'm going to go ahead and throw out two different emergencies that you need to know. Again, we're still talking about the thyroid. This time, we're going to be talking about Graves' disease, and we're going to be talking about thyroid storm. So with these two emergencies, understand that they come from hyperthyroidism. Hyperthyroidism. And the first one we'll talk about is Graves' disease. Graves' disease, it states here, autoimmune cause of hyperthyroidism. Now, what is an autoimmune disease? Remember, that's the body trying to attack itself, right? So your body is actually fighting against your thyroid, causing a whirlwind of problems. Now, the one most common problem that is seen is in this photo below. We call this exothalamus. And exothalamus is bulging of the eyes. Bulging of the eyes, something that's very commonly seen in exams. Another one is going to be anxiety, hyperthermia, agitation, lack of sleep, right? This patient's on overdrive. Their body is all out of whack. You could see just if you type in Graves' disease on the Google search, you're going to see a lot of photos of people with these eyes bulging out of their head. Now, let's quickly talk over some signs and symptoms of thyroid storm and why it's a little bit different and things I want you to recognize. Thyroid storm, it states it's acute, life-threatening hyperthyroidism, life-threatening. So if I'm taking an exam, and the exam is explaining to me that my patient has history of hyperthyroidism, I'm already thinking Graves' disease. But the second that they tell me that the patient is altered or that they have a fever, you need a light bulb that goes off that says, hey, they're talking about thyroid storm in this instance. But over here, you see that it could include hypertension, tachycardia, that's severe, and again, that AMS. AMS and fever to me are the tall tale signs on an exam that we're dealing with something a little bit more life-threatening than a Graves' disease. Treatment, it states, is supportive care. Oxygen, start an IV, nothing crazy, but cooling measures if the patient is hyperthermic. Consider that this patient might be dehydrated, and then obviously transport this patient to a facility for definitive treatment such as beta blockers and anti-thyroid medications to block that hormone. Now, there's one thing I want you to understand too about glands that is very common if they have a growth, like a goiter or a tumor. Growths on glands cause a increase or a stimulation of hormone release. So if somebody has a goiter in their neck, there is a higher chance that the patient will suffer from hyperthermia. So something to consider when reading exams or looking at photos, things of that sort, or maybe even having a patient of your own. Moving away from the thyroid, we're going to start talking about the pancreas. Now, this is probably going to be the easiest of the endocrine emergencies. This one you're probably going to be most familiar with because it is common, and it's hypoglycemia. Hypoglycemia, by definition, depending on the text that you look, might say it's a BGL less than 70. In this discussion that I'm going to talk to you about, I'm going to say less than 60. That is usually when I start to treat. That's what a lot of the text that I teach out of also states. Now, with hypoglycemia, once the sugar starts to drop into a dangerous area, the patient could become altered, and sometimes they look like they can be drunk. Sometimes they look like they might be having a CVA or some sort of stroke-like symptoms. The first thing whenever I have a patient that's altered is I need to assess pupils and BGL. Those are probably the two first assessments that I'm going to perform to rule it out. Likely, when you have an exam and you're taking a test, the one thing I want you to pay attention to is cool and clammy. Remember this. Cool and clammy needs candy. Cool and clammy needs some candy. This will help you in identifying the need for a early BGL check, and the potential need for dextrose. So another sign and symptoms it states here is seizures, unresponsiveness. Absolutely, the patient could have seizures and even unresponsive, like you see in the photo beneath me. So treatment, if my patient is conscious and they're able to swallow, I can go ahead and give them some sort of oral glucose. If my patient is altered at any point, I do not want to put oral glucose into their mouth, because then it could become a choking hazard. So be mindful of that. If my patient is unresponsive, I want to establish an IV and I want to give dextrose. Now, over time, dextrose has started to change. And what I mean by that is whenever we were treating adult patients with dextrose, we were using D50, 25 grams IV push. And the issues with using that concentrated of dextrose is that we were causing hyperglycemia. Now, because of seeing this over years and years and studies and different research, a lot of clinicians have started pushing, hey, let's go ahead and dilute that dextrose. So there's D25, which is the half of the concentration of D50. And then there's also D12.5 or D10, which is about 25% of the D50. And I'm seeing this becoming a lot more common in EMS to just use D10. So of course I added the dextrose 10% dose there of 5 mLs per kilogram, and we're going to be giving that as a drip over time. We're still using 25 grams. It's just diluted into a 250 bag. So let's say that you're unable to obtain an IV. Is there any other treatment we can use? Of course, glucagon, 1 milligram IM injections can be considered. Now, just from personal use, glucagon may take a while for it to take effect, and you need more than one. So for exam purposes, yes, absolutely, we're going to consider that as a potential treatment for our hypoglycemic patient. Next, let's go ahead and talk about DKA. DKA, diabetic ketoacidosis, is ketone production due to lack of insulin leading to a metabolic acidosis. So can we think about what kind of patient would be more prone to DKA? It says lack of insulin. Patients that lack insulin, we call this type 1 diabetes. And the unfortunate part, and I made sure to find a photo of a child where they're checking the blood sugar. A lot of the times they call type 1 diabetes juvenile diabetes. And the reason behind that is because this is when usually people find out that they are diabetic. And I hate to say that there are a lot of patients that do not get seen by a pediatrician till they start to show some serious signs and symptoms. Now, it's usually around 10 to 12, 10 to 13. I'm not saying that somebody can't become diabetic later on in life. It does happen, but this is very commonly seen. Now, there's one thing that I do want to mention about diabetes, and I should have mentioned this with hypoglycemia. Not everyone's the same. And let me explain that. Some people run high, and that's just normal for them. Right? There's some people that walk around every single day in the 300-400s, and their body starts to become accustomed to those high blood sugars. So if that person has a rapid drop into the 100s, they could start showing signs and symptoms of hypoglycemia, even though it hasn't gotten down to 60, for instance. But again, not everyone's the same. Some people that are diabetic, and depending on how they manage their insulin, they might be running really low, maybe in the 50s, but they are conscious and they're completely alert, and that's just normal for them. They're always in the 50s. They don't start to become altered until they're in the 30s, right? But if that person goes to 150, that's a huge deal to them, and they start to feel terrible. So just understand that diabetics, I know we give you a range, and it's good to understand the range, but in actuality, everybody's going to be different. So looking at DKA, this is a person that DKA is usually a more rapid of an onset. And it's, as you can see here in the signs and symptoms, it's between 200 and 600 milligrams per deciliter. And this patient starts to show some very interesting signs and symptoms. The first one, we got to mention it, the 3 Ps. Okay, polyuria, polydipsia, and polyphagia. That polyphagia with a G. I know I didn't write it there, but it's insinuated. Polyphagia just means increased hunger. And so those three P's are the most common thing that we see in exams for hyperglycemia. Now, once they start getting into the fruity breath and the rapid, deep breathing of Kussmaul respirations, this is when we note that our patient is in DKA. Okay. Another one that's commonly seen is that AMS, right? They start to become a little bit altered, confused, and they're having that deep breathing. Another sign and symptom that I made sure to put in here is a low end-tidal capnography. So you have somebody who's creating ketones, right? This ketosis is actually breaking down fat and causing an increase in hydrogen ions in the blood. By doing so, right, we're putting this patient into an acidotic state. And if you remember, acidosis is a low pH. And with a low pH, we start to have a decrease in end-tidal. Okay, with this patient in particular, this is considered a metabolic acidosis, and it's not uncommon to see end-tidals less than 25. So if I'm taking an exam, that might be something that I want to pay attention to. Treatment. IV fluids, absolutely. IV fluids is something I need to consider immediately for any sort of hyperglycemia. Monitor for potassium abnormalities, maybe an EKG reading. EKG readings can look like PT waves or maybe even sine waves. That's SINE, and that is a serious condition with high potassium. Rapid transport for insulin therapies. Again, man, DKA. If I'm a student and I'm studying to take an exam, I just want to really know these signs and symptoms and know that the only thing really I can do is treat it with fluids. Now, this last emergency that I'm going to talk about with the pancreas is considered hyperosmolar, hyperglycemic non-ketonic syndrome. Don't worry, I'm not going to keep saying that. I'm just going to call it HHNS. And it's hard to say that this is going to be more severe than DKA. What I will tell you is that the blood sugars are going to be higher than what you would see in DKA, but this is typically seen in patients that have type 2 diabetes. Okay, so this person typically does have insulin in the bloodstream, but it's just not being used appropriately. Okay, severe hyperglycemia without significant ketosis. And these patients are extremely dehydrated. So just right off the rip, you already know that this patient, it is mandatory that this patient gets fluids. Some signs and symptoms, again, severe dehydration, AMS, extreme hyperglycemia, over 600. Okay. And look at those end-tidals. The end-tidals start to become normalized. They're greater than 30. So remember, between 35 and 45 is considered normal, but don't expect that we're going to see these extreme low end-tidals like we did with diabetic ketoacidosis. Treatment is going to be IV fluids, followed by a hypotonic solution. Again, in the EMS setting, we might not have hypotonic solution. You might be using isotonic solution more than likely. The patient will benefit from fluids in general. Monitor for blood glucose and transport for definitive care. The patient needs to be treated and monitored in a hospital. Now, another thing that's not discussed in this patient in particular is airway management. Pay attention to the patient's vital signs. If we have good end-tidals, we have good SATs, and the patient isn't vomiting, you might want to just throw on oxygen and monitor. But if we notice that the patient maybe starts to vomit and we're worried about airway management, consider advancing the airway. So the last gland that I'm going to talk about is going to be the adrenal gland. Now, there are two different emergencies, and this first one that we're going to talk about is adrenal insufficiency. Adrenal insufficiency, also known as Addison's disease, or they also say Addisonian crisis. There's a lot of different terminology that gets thrown around, but just know that this is low hormones from your adrenal gland. Okay, it states here it results in inadequate cortisol production. The big thing that these patients will always have in common is the fatigue. If you watch any YouTube video of patients with Addison's disease talk about when they first found out that they were diagnosed, sometimes they say, like, I thought I was going to die. I had no energy. I couldn't even get out of bed. If someone got me out of bed, I would just fall back asleep. And the fatigue is real. Weight loss, it becomes a big thing. Hyperpigmentation is something that is often seen in exams. And I made sure to put the medical terminology, melanoderma. Melanoderma. I don't know if I'm saying that right. Melanoderma. It's noted in chronic Addison's disease. And you can see in this photo of this woman under me, she has that very dark pigmentation. And a lot of times these patients, they don't go out into the sun. They're not getting sun. So when you start to see this real dark pigmentation and they tell you that they haven't been leaving their house, this should be a reminder that this could be Addison's disease. Now, a couple things that before I go to treatment that I want to talk about. Hypotension, patient appears in shock, right? AMS and even abdominal pain. Remember, these patients are so fatigued, maybe they're not eating appropriately. They start to lose electrolytes, and these patients do require treatment for dehydration as well. So again, just jumping into treatment. First thing, IV fluids. Monitor for blood glucose. Hypoglycemia is a common sign that can be seen with Addison's disease. Now, this treatment down here is a little bit interesting because it's not commonly seen in EMS, but in most textbooks that I have seen that are paramedic related do talk about hydrocortisone. Now, hydrocortisone is a corticosteroid that is considered the golden standard to treat Addison's disease. It's 100 milligrams, IV or IM. That's a little bit debatable. Some books say IM is preferred. Some say IV is preferred, but you can do either or. And if you do not have hydrocortisone, you can also consider Solumedrol, same 125 milligrams IV or IM, but it's not as beneficial as hydrocortisone would be. Now, the last emergency, I'll talk over real quick, a couple others, but the last major emergency that I commonly see in exams from the adrenal gland is Cushing syndrome. Now, way different in appearance with Cushing syndrome versus Addison's disease. If we said Addison's disease was adrenal insufficiency, think Cushing's is going to be the opposite. Excess cortisol production, too much hormones being produced from the adrenal glands, often due to prolonged steroid use. Signs and symptoms, the first one that comes up, and these names are crazy, but it does help me memorize them. Moon face and buffalo hump. Moon face, becomes like a lot more adipose tissue or fat that starts to be placed in the patient's face and makes more of a round appearance. Another one is a large hump that starts to grow on the top of the patient's shoulder blades area, just beneath their neck. They call it a buffalo hump. And again, central obesity. And you can see all the striae that's occurring on this patient, or stretch marks, right? Hypertension, hyperglycemia, high blood sugars, very common in Cushing's. Muscle weakness. Acanthosis is an interesting one. And acanthosis is like a thickening, dark pigment of skin that you commonly see in the neck, armpits, and even groin area on these patients. Treatment, honestly, there is no treatment. There's nothing we can do. If I am to take an exam, they're not looking for me to treat Cushing syndrome. They're seeing if I can label Cushing syndrome based off of the signs and symptoms. So my recommendation to you is either listen to this a bunch of times so you can memorize it, or just make note cards, signs and symptoms, so you can call it out if you see it on a test. Two others that I can think of, maybe the parathyroid, hypoparathyroidism and hyperparathyroidism. And the only reason why I say I didn't want to make slides is I never see it on tests. I know you might have had that in your textbook, but the easiest way to memorize hypo and hyperparathyroidism is calcium. Hypoparathyroidism is hypocalcemia. The patient just needs calcium. And if you know that hypocalcemia will cause muscle twitching, that's how the patient's going to present. They just need calcium, either in chloride or gluconate. With hyperparathyroidism, the patient's going to have high levels of calcium levels, or hypercalcemia. The treatment for that is just fluids. So really not much we can do for that. Just fluids, just dilute the blood. So I hope this helps. If you have any questions, please ask in the comments below. If this is content that you are interested in, don't forget to like and subscribe and all that good stuff. With the new year, I do plan on making more and new videos. So stay tuned for that. I'll see you all in the next one.